Hello, this is Dr. Sargisian, and today we'll go over a review for exam 3. And this review is not comprehensive, but it will hit on major topics you need to know. And my focus is not only the exam, but your knowledge for your future professional life and also for your board examination and board certification. So first topic is cardiac, and cardiac will include abdominal aortic aneurysm and peripheral vascular disease, heart failure, and we'll talk in general about these topics. So, carotid artery disease, this is one of the important topics that we didn't talk before, and by before I mean the curriculum in undergraduate nursing. So this is a good time to talk about this. And this is our first topic, so I'll talk about how slides are built. Most every slide has pathophysiology and epidemiology, but I don't really want to go over pathophysiology or epidemiology with you in this review because pathophysiology you already been tested on that and you have that knowledge, and epidemiology is something you can look up. But everywhere I included it because it's important for understanding what's going on in this certain topic. So, risk factors for carotid artery disease. First and foremost, it's the age, because in many disorders, including this one, the older we get, the older a risk to develop certain disorder is. Unfortunately, there are not many that you would say the older I get, the less likely I will get this disease or disorders. So, what are the risk factors besides the age? It's most certainly atherosclerotic disease and hypertension, and also syncopal episodes unexplained may be related to carotid artery disease. So, if someone in evaluation part, now I'm talking, let's say you are a primary care provider and you hear cervical bruit, and it's on someone that has no previous history of anything really. And what would you do every time you hear a carotid bruit? So you have to order a ultrasound. So, and by ultrasound, I mean carotid duplex ultrasound. Anything else will be overkill, like you can do CTA, MRI, or angiography, but it's not appropriate in this situation. Bruit means you want to evaluate for plaque, and the ultrasound will be the best way to do it. So, what happens with this? Carotid artery disease is really a time bomb. Eventually, this will fire, and the sooner you catch it, and if you are diligent and wanted to do a thorough exam listening to carotid bruits, then you may catch it and prevent bad consequences. If it's not prevented, usually the person will have TIAs, transient ischemic attacks, and these are fairly common with carotid artery disease. If it's not taken care of, and you would think, wow, if someone has TIA, then they should be thoroughly evaluated. Some people will even not go to healthcare provider or a facility, and that will prevent further evaluation. But if this is evaluated, then you may start some kind of intervention. Again, TIAs are very common, and TIAs are usually precursor for a big stroke. So let's say if someone has a syncopal episode, syncope is not as easy from the evaluation standard compared to cervical bruit, because there are so many things can be related to syncopal episode. It can be neurological, can be stress related, can be cardiovascular, or can be quite common valvular, and again can be related to carotid artery disease. So another way to approach it to give a comprehensive exam to a person who will be presenting with syncopal episode, basically listening to the heart sounds, uh, doing a thorough neuro exam, and this is all happening, let's say, in the office setting. Obviously, we don't have the advanced equipment, but what you can do at least, listen to heart, do a neuro exam, and listen to carotid bruits. And after that, you can select your, you know, way, the direction you will be acting. So again, like I said, carotid artery disease is a precursor of TIA. TIAs are precursor of stroke. And really, this is all begins with atherosclerosis. And to reduce the chances of atherosclerosis and reduce the chances of stroke, one may undertake the following, which is pretty easy, but pretty easy to say, but difficult to implement, because increasing the intake of fruits and vegetables. If patient has diabetes, especially type 1, aggressively use the diabetes management. And of course, if it's type 1, then we're using insulin, and also utilizing Mediterranean diet, so-called. So this is all shown to reduce the incidence of strokes. So again, the treatment will be anti-lipid management, and also most of the time carotid artery disease, you will need to introduce surgical intervention and carotidectomy. So basically cleaning up the carotid arteries and getting them functional again. Sequela, as we discussed, it's the stroke, and we do not want that. AAA, abdominal aortic aneurysm. So what's aneurysm? Again, aneurysm is anything, any increase from normal side of aorta. So usually aorta is around 2 centimeters. So anything over 3 is considered aneurysm. You can apply wakeful watching or watchful waiting approach to this until aneurysm grows up to 5 centimeters. If it exceeds 5, then surgical intervention and aneurysm repair is important. So 5, according to some sources, 5 will be your upper acceptable number, and more than 5 will be something that you need to do surgical intervention. Risk factors include, again, age, male gender, although females can develop this too, smoking, and this is really smoking, not current smoking or 10 years ago, anytime in a lifetime, smoking, and some studies suggested even smoking as little as 10 packs during their lifetime, persons can have higher risk of abdominal aortic aneurysm. So again, the approach is if it's under 5 centimeters, do the serial surveillance. So periodically, every 6 months, send them for ultrasonogram. If aneurysm grows, then refer to surgical intervention. What if you found a pulsating abdominal mass on the exam? If you guys noticed, even on a healthy person, on very skinny and healthy person, you may see pulsation of the aorta and feel it. So contrary to popular belief that pulsating abdominal mass is always something abnormal, that's not entirely true. But if you actually see something significant and that goes along with that 5 centimeters, what would you do? Would you send them to surgery or you would do something else? No, you do not send them to surgery because you want to evaluate it further. And this is considering if the patient is stable. Again, if you are dealing with a stable patient with normal hemodynamics, but for some reason you are dealing with, or for some reason you are dealing, patient presents with pulsating mass, but otherwise doing well, you go with ultrasound. Ruptured abdominal aortic aneurysm is an emergency, immediate transfer of the patient to surgical facility or to emergency room, whatever is closer, and repair. Unfortunately, chances of surviving without very expedited repair are very low. So how to recognize ruptured abdominal aneurysm? Most of the time, you would notice that altered hemodynamics, patient's blood pressure may significantly drop, patient may have something close to or a syncopal episode, and again, pulsating abdominal mass. As much as they teach us in our previous years that pulsating abdominal mass, it's a ruptured abdominal aneurysm, most of the time ruptured abdominal aneurysm does not present with a pulsating mass. So the bottom line, if patient is stable, you have pulsating mass, do ultrasound. If unstable hemodynamically, they cannot maintain blood pressure, obviously it's ruptured, treat accordingly. And again, more than 5 centimeters, repair, emergent situation, repair, refer to surgery. It's easy to say in a lecture, I realize it, but this is the basics you need to know. And the best way to approach it to determine who is at risk, who I need to screen, and you can screen the people who are over 60 years old and have history of smoking. You can screen them one time and most insurances will cover it. Peripheral artery disease is also related to aging in a sense that, yes, age is the risk factor. On the other hand, it doesn't matter if you are aging that you will develop all these diseases, but the opposite is rather true. Okay. So how patient will present? They will usually complain of leg pain, leg fatigue, and the pain is it's really soreness and my legs are getting tired, and usually with daily activities normal. It's not like engaging in strenuous exercise, and this gradually comes up. So what would you notice on the exam on a patient like this? That they will present with decreased pedal pulses, or maybe In severe cases, the pulses will be absent on palpation, so you need to use Doppler to establish those, to find those. So what you do in this situation, if you are, and by Doppler I'm saying portable handheld ultrasound with uh, headphones, but you should do, if patient presents with the symptomatology, you may consider ordering a real ankle Doppler and also proceed with arm index. Okay, risk factors again is aging, atherosclerosis, and history of smoking. So treatment and management most of the time will be surgical referral, but again, you have to establish what's going on. That's why, like, as you guys notice, I like to get to the bottom of like screening, evaluation, and diagnosis part on everything. And if we can treat it, we'll treat it. If we cannot, we will refer the patient. But it's highly inappropriate just based on just limited information to refer the patient. There are lots of, I want to say most, I apologize, there are lots of conditions you can manage successfully in primary care. Okay, heart failure is an extremely complex diagnosis, and there are lots of modalities involved in this. I mean, pathophysiology, how heart failure happens, and what happens with the heart. Heart failure is very complex, and I don't want to go back into patho, but at least you guys need to know that left-sided, right-sided. So left-sided heart failure will require to some type of increase as your treatment of ventricular systolic function, so either pharmaceutical or left ventricular assist device. Left-sided will present with ejection fraction decrease. So EF is still dominate this field. EF is the king. EF is the diagnostic. So if you are suspecting the heart failure, you need to order cardiac ultrasound with echo cardiac ultrasound, and then you will determine your EF and treat accordingly. When this happening most commonly, you may read and find out the information, yes, that hypertension may lead to heart failure. Yes, it may, but the most common risk factor is history of myocardial infarction, because heart failure, basically after myocardial infarction, you have the incapable cardiac issue or non-functional cardiac issue, and that leads to heart failure. So the treatment is rather intricate, and to treat, you have to determine classification of heart failure. Okay, my favorite, and the same advice is to you, and not only my favorite, but most commonly accepted and less confused, is New York Heart Association classes. So as you see here, there are 4 classes. First class is really pre-heart failure. There may be some changes, but your patient will not have any symptoms or complaint. Second is small decrease in exercise tolerance. Third, significant decrease in exercise tolerance. And 4 is symptoms even during rest. So the most confusing part here is difference between second and third. And second, again, it's intolerance of marked exercise, so heavy exercise. And I realize that heavy exercise is very comprehensive term, so something like playing golf or playing badminton or swimming leisurely. So it's still exercise. So if patient cannot tolerate that, they are class 2. Significant decrease in exercise. That means that patient doesn't tolerate mild exercise. Mild exercise means they are not able to clean the house, or they are not, or they are having symptoms when they are cleaning the house, or they are having symptoms getting up from the bed and going to the bathroom in the middle of the night. So doing something that takes a little bit of effort, but it's not really usual sedentary routine. And fourth is basically you having trouble at rest, or even in the while turning in the bed, you may have symptoms of heart failure. So please remember this. This classification is very helpful. The next one is pharmacology and management of heart failure. You see how we graduate from very benign interventions to some very drastic, like transplant or left ventricular assist device. Again, there is an American Heart Association and American College of Cardiology stages, which sometimes correspond, sometimes not, and this table is rather simplified. So I want you again to focus on New York classification. Okay, so again, New York classification was first one, your patient doesn't have symptoms with normal exercise, but will have with severe exercise, and some say it's pre-failure, but it's really not. But if they're having this, then you may consider ACE inhibitors, ARBs, and beta blockers, and also diuresis possible. Second or third, you will add aldosterone as a diuretic. Also, uh, or aldactone, I'm sorry, not aldosterone, aldosterone antagonist. Okay, so, and then you would graduate to left ventricular assist device. Diuresis is very important in patients with heart failure. And as we all know, patients may develop tolerance to certain diuretics, like loop diuretics, like furosemide. Then at that point, you can throw in another class, and metolazone is a thiazide-like type diuretic, but metolazone is one that you may supplement the furosemide therapy when it's not effective anymore. Again, aldactone is a little step up. So if basically I would throw in the metolazone first and then aldactone. So again, important, and it's not in this table, sodium restrictions for heart failure, overall like healthy lifestyle, diet, and tolerable, manageable exercise. But again, prevention is a key. Obviously, if you treat everything in the first line, your patient may end up healthy and doesn't need all these extensive interventions. Pulmonary disease, and we'll talk about several pulmonary disorders here. Cough. So cough, you would say it's a symptom, and it is, but we need to know how to treat it and how to evaluate it. What's causing it? So if patient has unexplained cough, then you may look into several domains. Is it a medication side effect? Is it an infection? Or even is it gastroesophageal origin? Is it allergy? Is it allergic rhinitis, postnasal drip, or sinusitis? So you need to look into all of that. Okay. So also, you may think maybe this is asthma. So if it's asthma and if you're thinking it's asthma, you may try to do methacholine challenge test. Basically what it does, it simulates, like, it's called bronchoprovocation. Basically it tries to create a asthma type spasm, the medication methacholine. Okay, so again, asthma should be on the list while you are thinking about this, because you would be eliminating everything else. So again, asthma is like one that comes to mind. If patient doesn't have history of infection, like pneumonia or bronchitis recently, if patient doesn't have gastroesophageal reflex, like if severe reflex can penetrate and cause cough, patient doesn't have medications of certain characters. ACE inhibitors are notorious for this for some patients. And you don't have a history of COPD, so then you think asthma, and then you will do methacholine challenge test, so to initiate that bronchoprovocation. Okay, so another somewhat disorder that stands apart, kind of, because most of bronchitis and pneumonia will resolve in relatively short time. But if it's myoplasma pneumonia infection, then the cough symptoms may linger for very long time, 6 weeks, 8 weeks, you name it. So it really stays long time. So while regular bronchitis may go away relatively quickly, but if patient has myoplasma pneumo infection, then it may linger for a long time and even be like, even patient may forget that they had a pneumonia or bronchitis, but still you have to consider that. And basically, patient presents with chronic cough and everything else is normal, then it's just leftovers of myoplasma pneumo infection. COPD is a rather comprehensive topic, and it's a big topic, but I want to just hit on the main things. Pathophysiology, of course, smoking and irritants, they will lead constant exposure to the irritant agent will lead to development of COPD. Some people who never smoked, they still may develop COPD if they had alpha-1 antitrypsin deficiency. And that's, unfortunately, those people didn't do anything to hurt their health, but they still will develop COPD because of alpha-1 antitrypsin deficiency. Epidemiology is quite wide, but it correlates with smoking rates. And of course, sequela, the COPD is non-curable disease, and if patient doesn't stop smoking, it will progressively get worse. If patient stops smoking, it's possible to halt the progression of the disease, but reversal, unfortunately, impossible. So how you evaluate? There are many ways to evaluate, even by visual examination, like seeing someone in a tripod position, which will lead you to COPD diagnosis, but most certain way is conducting spirometry for FVC and FEVs, and that way you will have a certain definite diagnosis. Okay, so we can talk about this long and boring about COPD, but again, I think prevention is the key. People should realize that smoking is no benefit. Unfortunately, you still see people who smoke, and eliminating the smoking will help to prevent or at least halt the development. One last thing I want to talk about, which we don't talk much in our previous studies, is, as you guys know, the COPD is most of the time is combination of emphysema and chronic bronchitis, but these are two different distinct disorders, and they can appear separately, although it's rare. But so how to differentiate which component is emphysema and which component is chronic bronchitis? It's pretty easy because emphysema affects lungs and bronchitis affects airways. So if you suspect that patient has bronchitis, they will not have lung compliance issue, or they will have very small lung compliance issue. Basically, the alveoli will still be able to expand and collapse. But if it's emphysema, the compliance of the lung tissues are lost, and it's severe compliance issue with emphysema. So that's how you can differentiate, but this is rather hypothetical debate because usually these two go together. In rare cases, you can see separate cases of emphysema and chronic bronchitis. Then you look at lung compliance. Obviously, emphysema affects lung compliance severely, while chronic bronchitis does not. Lung cancer is one of the most debilitating diseases, and it's still prognosis of lung cancer are relatively grave. It's very difficult to treat, and this is basically for your information only, the slide. And as primary care providers, we will not be treating lung cancers, we will refer, but you need to know how to evaluate, how initiate the process. So evaluation should include, if someone comes with unexplained cough, especially hemoptysis, then you may consider further evaluations for lesion in the lungs. Hemoptysis can signify two disorders. It's tuberculosis and lung cancer. So you may do imaging, you may do CT of the chest, or you may do TB testing, but again, the bloody sputum may signify, or hemoptysis, not really bloody sputum, may signify lung cancer. So imaging usually will give you an answer to this. And unfortunately, smoking, again, still a significant risk factor, or exposure to carcinogens like asbestos. And the prognosis is rather grave, especially with small cell lung cancer. The chances of recovery are relatively low, and some patients may experience temporary improvement after initiation of the chemotherapy. However, this is transient effect, and patient may not achieve remission. Again, it's difficult to treat, and temporary improvement after chemo starting will not lead to marked improvement or like remission, permanent, or you cannot really say permanent remission, but lasting remission. Pulmonary hypertension, and again, you need to know what happens and how to deal with this, and common risk factors, how you evaluate it and how you deal with it. So patient may present with changes in their cardiac assessment. They may present with increase in their heart sounds. It's very common to hear a loud second heart sound, and also you would see that patient will have the jugular vein distension and edema. So pulmonary hypertension can lead to right ventricular dysfunction or right ventricular heart failure. So treatment and management is you may basically, when you establish the diagnosis of pulmonary hypertension, again, it's a referral, and I don't want you to focus on that, but there are certain medications that still play important role in management of pulmonary hypertension, such as sildenafil, and basically our goal is not to cure pulmonary hypertension, but to keep it at manageable level, and prevent right ventricular dysfunction if possible. But again, right ventricular dysfunction is rather common complication or right-sided heart failure. Tuberculosis is an infectious disease that affects the lungs, and I want to focus on this review how you would screen and test for tuberculosis, because Mantox's single test is still gold standard. Some healthcare facilities, especially when they ask for clinicals for students, they would like to have a two-step TST. However, single Mantox test is the gold standard. So single test is sufficient for screening. Okay, so how you interpret the single test? So negative, positive results. 5, 10, 15. So those are the millimeters. So 5 millimeters is positive if patient is immunocompromised. Let's say has HIV. It's positive if patient had a recent contact with someone who had tuberculosis. Okay. So, but those are like relatively rare circumstances. And again, key point is relatively. So 10 millimeters is positive in, let's say, immigrants from high prevalence countries, healthcare workers, injection drug users, and so on. So basically 10 milliliters covers lots of categories, and I really don't know anyone who doesn't fall into that category. So again, like people who work in lab, people who work in the hospital, people who in contact with lots of people, high risk categories, infants, children, and so on. So 15 millimeters is something that it's positive on a person who never been exposed to anything, just lives very isolated life in their home, and then occasionally goes to shop for food and groceries and then comes back home. So that's 15. But most of us will fall under 10 millimeters category. So again, that's your screening test. Again, please know those and know how to interpret them. How you treat. It's usually a referral to infectious disease, but again, you want to know the modalities of treatment, because in some places you may end up treating it in primary care, and treatment is rather simple. Okay, so there are new ways to even diagnose and assess. So there is this new expert MTB RAF assay that will be determining if the patient has TB and the drug resistance against rifampin. So it's pretty cool, and it takes only a couple of hours, which in old methods you would spend like several weeks trying to get the results. So what's the best treatment regimen? So isoniazid and rifampin are most commonly done regimen and combination, and you even can give it once a week. CDC has this campaign saying 12-dose tuberculosis treatment, which is great. Basically, for 3 months, you give 4 doses every month and you are done. However, it's not the most effective treatment. Most effective treatment is isoniazid daily. So daily isoniazid. So in test question situation, when something like this comes up, and I know we all are in graduate school or beyond, but still people get confused. Don't presume the circumstances. Don't think that something else going on the background unless you know from the question. So when test question asks you to pick a treatment, please pick the most effective. So it's isoniazid daily is the most effective treatment. So again, if there are no other circumstances, like if the non-compliance or so on are issues, then yes. But if it's not spelled out, your isoniazid is the most effective treatment daily regimen for 6 months. Next topic is GI, and the GI will cover IBD, IBS, and some other topics. And one of the other topics is cirrhosis. Cirrhosis is debilitating disease, and frankly, in my healthcare and my nursing career, I think this were people who had cirrhosis were the sickest and the sickest looking people. And I have a special spot in my heart for people who have cirrhosis, because this is really not curable disease, and it only can get worse. But there are treatments available, and even the cure with transplant is available. But it's still very, very debilitating and very bad disorder to live with. So again, pathophysiology and epidemiology, I will leave it alone for now, but risk factors can be alcoholism, or can be any disease that can cause inflammation of liver, and so-called itis, appendicitis, bursitis, or hepatitis. It can be alcoholic hepatitis, can be hepatitis C, or can be just hepatitis of unknown origin. But any inflammation can eventually lead to cirrhotic changes. Common misconception, the Trinity, I call it, people who drink, they will end up with alcoholism. It is not true. Only certain amount of those will end up with habitual drinking and alcoholism as a disease. People who have alcoholism, they all have cirrhosis. This is not true only. Only certain number of people who suffer from alcoholism will also develop cirrhosis. So I'm not saying here that encourage your patients to drink, but also you need to know that we shouldn't assume that anyone who has affinity to alcohol or alcoholism, they have cirrhosis, which they don't. But of course, they are much more susceptible than anyone else, and the risk is very high. Okay, how you evaluation of cirrhosis, you can do imaging, ultrasound, and see the enlarged liver, CT scans, and liver biopsies. Also, in early stages, patient may not have many changes. They may have weight loss, they may have fatigue, and they may have pruritus. They may be very itchy because of bilirubin accumulation under the skin causes the itch. So every time someone comes with a complaint of itching profusely all over, and you do not see any lesions like from poison ivy, think about bilirubin accumulation and itching, pruritus because of the liver failing or cirrhosis, so basically liver dysfunction. So it's important to know how to recognize it and follow up accordingly. So you may follow up with liver function tests, and you also may end up checking CBC to evaluate the blood cells, blood lines, and also you may end up checking the clotting factors. But again, clotting factors, dysfunction may come late in the disease. In the beginning, you may see only mild elevation of liver enzymes. So how you treat patient with cirrhosis. Again, there's really no cure. The only cure is liver transplant, yeah, like you see here. So how you would suggest them to proceed? If disease isn't severe, and you may consider alcohol cessation, avoid NSAID, and also sodium restrictions. 2 grams a day, same restriction can apply to your patients with heart failure. If it doesn't improve, then we may start oral diuresis. Why are we doing oral diuresis or restricting sodium on someone with liver disease? The reason is because portal vein is affected and patient will develop portal hypertension, and as a consequence of portal hypertension, they will have accumulation of fluid in the abdominal cavity or ascites. So you are trying to manage ascites by doing this intervention. So most people who have portal hypertension and cirrhosis, or with cirrhosis, they most certainly will have portal hypertension. They will be on oral diuretics. Please remember this combination. It's spironolactone, 100 milligrams, and Lasix, 40 milligrams. The research suggests, and evidence suggests, that this combination is the most perfect combination for managing ascites secondary to cirrhosis and portal hypertension. It's not Lasix alone, and it's not aldactone alone, but it's this combination, 100 to 40. If you want to increase, you may double or triple that. You can increase it every 3 to 5 days, but again, this ratio 100 to 40 should stay. And it's been shown that this is the ratio works the best with ascites. What if this fails? Then you would start conducting paracentesis with albumin infusion. So basically, when large volumes of fluid evacuated from the abdomen, patient will lose lots of albumin, and to avoid hypoalbuminemia, you will give the injections intravenously of albumin. And then we are getting into specialty domains, into TIPS, transjugular intrahepatic post-systemic shunts, and then liver transplant. But again, from this slide, I really want you to know oral diuresis management, because you may have patients like this. This regimen may be initiated by hepatology specialty or gastroenterology specialty, but the primary care practitioner will be the one who manages this. Inflammatory bowel disease, as it says in the name, it's based on inflammation and inflammation of the intestinal lining. And again, like I was saying previously, this is a specialty domain, but again, more and more we see that the IBD is managed in primary care setting when initial diagnosis is done by the specialty. So what's the best way to diagnose? So first and foremost, patient will present in IBD, which has two different types of disease, Crohn's and ulcerative colitis. Patient will present with repeated episodes of diarrhea, uncontrolled diarrhea. In case of ulcerative colitis, there are also blood, gross blood visible in diarrhea, while in Crohn's you don't see it. But the sure way to determine what it is, it's the colonoscopy with biopsies. Only the pathology report will reveal if it's truly Crohn's disease or ulcerative colitis. Treatment can be very simple, from sulfasalazine to biologics, and such as Imuran and Humira. However, something simple like sulfasalazine may be again conducted in primary care practice. Okay, so sulfasalazine is the cornerstone of treatment, and it's very cheap sulfa drug. You need to know two things: that A, it's a sulfa drug, so if patient has sulfa allergy, then you may decide to pick something else, and B, the treatments, unfortunately, there's multi-dose regimen daily, so it's 3, 4, 5 times a day, which is obviously inconvenience. You are monitoring the patient for recurrence of symptoms and prevention, and you are trying to prevent the exacerbation. And if the exacerbation occurs, you may manage it with oral corticosteroids, or even in severe cases with hospitalization, you may retreat to intravenous corticosteroid administration. Irritable bowel syndrome is a very interesting phenomenon, and it's a cluster of symptoms. Irritable bowel syndrome is combination of diarrhea or constipation with abdominal pain. So patient may have diarrhea predominant or constipation predominant, IBS, but it's not IBS unless your patient has abdominal pain associated with constipation or diarrhea. Okay, so some patients may even have alternating diarrhea and constipation, but again, abdominal pain is the key component of making this diagnosis. IBS is a diagnosis of exclusion, so you have to rule out infective cause, and you have to rule out inflammatory cause such as Crohn's disease or ulcerative colitis. And after that, you can say, yes, it's IBS. Okay, IBS is usually related to some type of trigger or either psychological or food related. So it's important for patient to keep a diary of food and symptoms. So see what they ate every day, they have to write down, and then they have to also put their bowel habits, how many times they went a day, and so on. So triggers can be again psychological or they can be actual foods. Diarrhea can have many sources. And like we talked previously, it can be inflammatory source, like Crohn's disease, ulcerative colitis, or it can be IBS, but it also can be infective source, I'm sorry. So you have to be able to evaluate. Most of the infective sources may resolve by themselves by the time that the lab results came back, like so-called traveler's diarrheas, but some of them can be very severe, like Clostridium difficile infection. Clostridium difficile infection is one of the serious ones, and you have to approach it very diligently because it can affect patients significantly and even be present with significant mortality when patients develop Clostridium difficile infection. So every time patient having unexpected profuse bloody stool, bloody diarrhea multiple times a day, suspect C. diff or any other infective cause unless it's proven otherwise. So I know that this may present as ulcerative colitis, but again, the first step in evaluation is ruling out the infective source. So if patient presents with profuse diarrhea multiple times a day, with or without blood, first step should be testing stools for infections and especially for Clostridium difficile. The next category is genitourinary. And prostate cancer is one of the cancers that is relatively prevalent. However, the mortality of prostate cancer is relatively low. There are many factors that can affect development prostate cancer, such as diet and heredity. However, I would say hype about prostate cancer is in the past. I remember 20 years ago, there was so much emphasis placed on testing for prostate cancer and doing digital rectal exam, but these days we are not so keen about testing and especially treating prostate cancer. The reason for it that many prostate cancers are self-contained and they have low probability of being aggressive and spreading into metastasis. So some patients may elect not to have the treatment because they have heard horror stories of having prostatectomy and not being able to maintain continence, or it will affect their sexual functions, and they may elect not to go with the treatment. At that time, depending on the severity of the disease, you may elect to simply monitor PSA and see if the prostate cancer progresses. If prostate cancer progresses, means there's significant change in PSA, you may revisit the topic of surgical intervention with the patient and see what they think about it. But overall, these cancers are not very aggressive, and people may live very long with untreated prostate cancer. There are conservative ways of treatment of prostate cancer. There is estrogen therapy available, or again, watchful waiting, just I would describe. But again, every patient is different, so you can have individualized approach in this. Again, monitoring PSA in a patient with prostate cancer is important, and that may direct your interventions in the future. Chronic kidney disease is a topic that can affect many people, and it's usually the reflection of renal failure. So what types of renal failure you have? First one is renal, which is pretty simple, that kidneys are affected themselves and they are not working. So that's a renal failure. Post-renal is also pretty simple. You have a renal stone lodged in a ureter, and that blocks outflow of the urine, and it increases pressure in the kidneys and causes damage. But what about pre-renal? Pre-renal is one of the poorest understood, and by poorest understood by probably when we study for it, it takes the most time to grasp it. So, but eventually we get it. So pre-renal is kidneys are affected by factors outside the kidneys, and it can be blood flow to kidneys. So basically you have a tumor on renal artery, and so there's not enough blood flow, or you can have a anaphylactic shock, and that also affects the blood flow, excuse me, or the kidneys itself. So this is all factors that lie outside of kidney. So, and that's why it's important to differentiate. So pre-renal is the most complex, but think about it being outside of kidney. Anything like anaphylaxis, even hypertension, renal artery stenosis, something like that, they all can cause pre-renal failure. So evaluation, you want to evaluate the GFR. You also want to see how much albumin is slipping out into urine. So I want you guys to know what microalbumin urea is, and normal albumin to creatinine ratio is less than 30. That's normal. If your ratio is increasing from 30 to 300, it signifies microalbumin urea. When that ratio is surpassing 300, it's turning into macroalbumin urea. Of course, the higher number corresponds to the severity of disease. But again, I want you to know definition of normal albumin to creatinine ratios, which under 30 is normal, 30 to 300 is microalbumin urea, more than 300 is macroalbumin urea. So how you stage chronic disease, chronic kidney disease, and how you manage it. Again, this is, I keep saying specialty domain, but it doesn't give you a free out of jail card not to know how to manage this. So we are looking at GFR. Normal GFR is more than 90. If it's 60 to 90, then it's a second stage, and so some deficiency. Moderate is 30 to 59, severe is 15 to 29, or more less than 15 it's needed. Probably patient will be on dialysis. So patients with kidney disease will have uh, anemia, and it will be anemia of chronic disease because they will not have ability to produce erythropoietin. They also will have blood pressure increases. Patient may have problems with calcium, potassium, hyperparathyroidism, and levels of phosphorus and ventricular hypertrophy, and also of malnutrition. Please remember that hyperkalemia is very um, specific for chronic kidney disease. There are two main causes of hyperkalemia. It's kidney disease or overdose with potassium. So next topics are about sexual dysfunction. And sexual dysfunction here, it's mostly discussed about the male, but sexuality, as you can see in this picture, affects men and women, or you see same-sex couple, or people under the question marks who do not associate themselves with any gender or sex. So erectile dysfunction is one of the conditions that moved very rapidly several decades ago from specialty domain to primary care domain. And you need to know how to treat it, how to evaluate it, and how to manage it basically with pharmaceuticals. So pathophysiology is important here. I want you guys to know that erectile dysfunction lots of time is a reflection of what's going on in the body. So it can be related to cardiac conditions, or it can be related to diabetes. So it's always a good idea to check at least those uh, labs, like check for blood glucose and check for lipids, and see where the patient is standing there, because it can be a reflection of those. Because obviously the erectile function is tightly related to vascularity, and high level of blood glucose will cause the endothelial damage, and that which in turn will result in erectile dysfunction. But anyway, you may treat it in primary practice, and you do not need to refer simple cases to a specialty. So when you establish the diagnosis, you do not really have to do a physical exam of the patient, like genitals, or like do extensive questionnaire, but this is completely based on patient history, the evaluation, unless you are looking for some other conditions. But again, if you are evaluating for erectile dysfunction, this can be done not only by historical evaluation. So after the diagnosis, you may start 5-alpha dehydrogenase inhibitors like sildenafil, Viagra, or tadalafil, and usually this medication working fairly well. If those don't work, my advice will be to refer the patient to specialty, to urology, and let them manage that, because they may have other things they may try, such as intracavernosal injections, not infections. Hypoactive sexual desire is different from erectile dysfunction. However, this may be confused by lay public, and the hypoactive sexual desire can be viewed as decrease in libido. So what can you do about it? So first and foremost, the evaluations. Very commonly, this can be related again to another organic cause, cardiac disease or diabetes or neurological disorder. So this has to be all evaluated and eliminated. In males, this also can be a lack of testosterone or hypogonadism. So if hypogonadism is corrected, then the sexual desire may get to the normal level for that individual. But again, the treatment is very individualized, and sometimes it may need the referral to a specialty, again, someone who specializes in this particular problem. And again, make sure that when you are interviewing the patient, the patient knows what's the hypoactive sexual desire and what's the erectile dysfunction, because people with hypoactive sexual desire may have normal excitement, they may have normal ability to achieve erection and orgasm, but they do not have desire. While in erectile dysfunction, your patient may have desire, but they may not be able to achieve erection and ejaculation. And again, in both disorders, I didn't mention in erectile dysfunction, it can be related to medications as well. So you need to do a through medication inventory. Okay. Next one is infectious diseases. And in infectious diseases, I have only one topic, which is HIV infection, and I don't want to focus too much on it because especially on the treatment, because treatment is literally changing every day, and there are more and more treatments available. And while many years ago HIV was a death sentence, these days it turned into chronic disorder that is managed very, very successfully with pharmaceutical PO medications. Okay, but several things you need to know. What are the risk factors? Who needs to be screened? And what you do when the screening came up positive. So when the screening comes up positive in old days, some would even suggest to delay the treatment because just let's wait till viral load goes higher. Now we recommend the treatment to start as soon as possible. So doesn't matter if it's what's the condition of the patient. If they are able to tolerate the treatment, they may be older, younger, they may be pregnant, but you still recommend the treatment to start ASAP. Okay. HIV is not curable, so patients on antiretroviral therapy will develop normal CD4 counts and viral load will become undetectable, but it doesn't give you or the patient permission to discontinue the treatment. Unfortunately, this is a chronic lifetime treatment, at least at the stage of the science development now. So after you establish normal CD4 counts and undetectable viral load, it's important to do monitoring of viral load and CD4 counts every 3 to 4 months and continue the treatments. So HIV infection predisposes the patient to an immunocompromised status. However, if the patient is treated, they may not be truly immunocompromised, but still you have to be more cautious approaching to them. If patient with HIV has, let's say, been tested for tuberculosis, then you may be extra diligent in that. You remember when I was talking about TB, I was saying 5 will be for people who have HIV or some kind of immunocompromised status. So that situation still applies. So let's say someone tested positive, and it means in this situation, uh, definitely less than 10, but even 5 will be fine, will be diagnostic. In that situation, if you tested someone for that, you may proceed with further evaluation. Again, if it's tuberculosis you're looking for, remember positive Mantox test is warrant for your next step to do a chest x-ray, then to look for it. So this is our last slide and it concludes our session. But please let me know if you have any questions. You know how to reach me and I'll be available, and I wish you good luck on this test.